Heart disease is the #1 cause of death in both men and women globally and claims more lives than all forms of cancer combined. Cardiac arrest may be caused by almost any known heart condition and is often fatal if appropriate steps aren't taken immediately. Cardiac arrest does not discriminate. It can affect all ages, genders, nationalities, and races. This is why early recognition and immediate cardiopulmonary resuscitation, or CPR, are crucial for survival from cardiac arrest. Healthcare providers are the backbone of the systems of care in both the community and medical facilities. Advanced rescue measures cannot be successful on their own without solid basic life support, or BLS. This training will guide you through the key practices of high-quality BLS.
On any given day and at any time, you could encounter a victim of cardiac arrest because about every 90 seconds, a person dies of sudden cardiac arrest. But with the training you receive today, your actions can give a victim the best chance of survival.
Sudden cardiac arrest occurs without warning or within just a few minutes after symptoms appear. The term heart attack is often mistakenly used to describe cardiac arrest. Although a heart attack may cause cardiac arrest and sudden death, they are different conditions. But it's important to call emergency services for both. There is more information on the differences between heart attack and cardiac arrest in your provider manual.
Throughout today's course, we'll review the BLS skills you have learned previously, including adult BLS, child BLS, infant BLS, use of an AED, and high-performance teams.
In this video, we'll revisit each skill and use practice while watching, where you'll practice along with the video. Before you're tested on adult and infant BLS skills, you'll have plenty of time to practice.
First, let's talk about the 2 adult chains of survival. One is for out-of-hospital cardiac arrest, and one is for in-hospital cardiac arrest. Both chains have 6 links, but the links differ slightly. Both chains include activation of the emergency response system, high-quality CPR, early defibrillation, post-cardiac arrest care, which may be provided in the cath lab or the intensive care unit, and recovery.
For the in-hospital chain, the difference is the first link. It focuses on early recognition and prevention of cardiac arrest with patient monitoring and assessment, and, if necessary, rapid response by the medical emergency team when a patient's condition starts to deteriorate. For the out-of-hospital chain, the difference is the 4th link, which focuses on advanced resuscitation. In this link, a multi-rescuer team arrives and takes over CPR and may perform additional advanced interventions.
In this practice session, you'll check for scene safety, check for responsiveness, practice chest compressions, and provide breaths by using your pocket mask with a one-way valve. You'll practice while watching by doing 3 sets of 30 compressions with 2 breaths.
So, in 3, 2, 1.
Hey, are you okay? Are you okay? Help! Someone help! Activate the emergency response and get an AED. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Cover use of an AED and a bag mask device. AEDs vary according to the model, but all operate in basically the same way. You must be familiar with the AED used in your particular setting. The 4 universal steps for operating an AED are as follows. Power on the AED and follow the AED prompts. Attach the AED pads to the victim's bare chest. Follow the placement diagrams on the pads. The AED will prompt you to clear the victim so that it can analyze the heart rhythm. If the AED advises a shock, it will tell you to clear the victim. If no shock is needed and after any shock delivery, immediately resume CPR, starting with chest compressions.
You'll need to consider a few special situations when using an AED. First, if the person's chest is so hairy that the pads can't adhere to the skin, you may quickly shave the area if a razor is provided. If no razor is provided and you have 2 sets of pads, apply 1 set to the hairy chest. If the chest hair prevents the pads from contacting the skin, the AED should tell you to check the pads. If it does, press them down more firmly. If they still aren't sticking, rip the pads off forcefully, removing the chest hair. Then apply a new set of pads to the bare skin.
Excessive water on the victim's chest can also be a problem. It could allow the shock to travel through the water between the pads, ultimately preventing delivery of an effective shock dose to the victim's heart. If a victim is lying in water, quickly move them to a dry area before using an AED. But if the victim is lying on snow or in a small puddle, you can use the AED. And if the chest is covered with water or sweat, wipe it off before attaching the AED pads. But wipe the chest quickly. It doesn't have to be completely dry.
Some people have an implanted pacemaker or defibrillator in the same place where you would put the AED pads. These devices look like a round or square lump that's smaller than a deck of cards. If you see this lump, avoid putting a pad directly over it. Also, don't place a pad directly over a medicine patch. If a medicine patch is located where you need to place a pad, take the patch off and quickly wipe the chest before applying the pad. If the victim is wearing an undergarment containing metal, be sure to apply the AED pads on bare skin, avoiding contact with the garment.
You should familiarize yourself with the AED model in your workplace. Regardless of the type of AED, remember to turn it on first and follow the audible prompts that will lead you through the rest of the steps. AED kits may include additional emergency equipment, such as scissors, razors, wipes, gloves, and a barrier device. These items may also be found in a separate emergency or first aid kit.
We'll pause here to allow you to get familiar with the AED in your class today. Your instructor will show you all that's included in the kit and demonstrate the correct way to place the pads on a victim.
Providing effective ventilation is critical to successful high-quality CPR, especially in respiratory-related emergencies such as drowning, anaphylaxis, and asthma. Guidelines recommend against excessive ventilation during CPR, and research suggests that some rescuers are less confident and less effective when using a bag mask device on their own without assistance. Because using a bag mask device is such an important skill and is common in the healthcare setting, we'll work on it now. Bag mask devices consist of a ventilation bag and a face mask, and they come in a variety of sizes. You can also use supplemental oxygen with a bag mask device.
To begin, position yourself directly above the person's head. You'll use the EC clamp technique to hold the mask in place. To do this, apply the mask by first placing the cushion at the narrow end of the mask onto the bridge of the person's nose. Then lower the mask fully onto the face, watching for the cushion to bulge as it initially seals against the face. Form a C with the thumb and index finger of one hand and press down on the dome of the mask toward the face to further seal the rim of the mask. The remaining 3 fingers of that same hand should form an E to reach past the edge of the mask along the bony rim of the jaw. To tilt the head back, lift the jaw toward the mask and open the airway.
Make sure you squeeze the mask with your thumb and index finger while lifting the jaw to achieve an airtight seal between the mask and the face. And squeeze the bag with your other hand or push it against your leg or body. If the chest doesn't rise with each breath, you're not providing adequate breaths. If you don't get chest rise, readjust the mask, reposition the head and neck, and try again to ventilate. And then, only if necessary, administer a larger amount of air, just enough to get chest rise.
The critical points of delivering breaths remain the same for the bag mask device as for the pocket mask. 2 breaths are given, with each breath given over 1 second after every set of 30 compressions. Be sure to deliver each breath over 1 second with just enough volume to make the chest rise. Delivering breaths in this way will reduce the chance of gastric inflation, or air going into the person's stomach instead of the lungs. Gastric inflation can cause vomiting and possible aspiration.
If you have multiple rescuers, the most effective way to deliver breaths with the bag mask device is to use the 2-person technique. One rescuer focuses on keeping the airway open and securing the mask, while a second rescuer squeezes the bag to deliver breaths, just enough to cause the chest to rise. The first rescuer will use both hands to seal the mask to the person's face and lift the jaw. The thumbs and index fingers of both hands each form a C to seal the mask against the face, and the 3 remaining fingers of each hand will form an E for lifting both sides of the jaw into the mask. Be careful not to press too hard on the mask, which could push the jaw down and block the airway.
Now it's time to practice the 1 rescuer bag mask technique so that in a few minutes, we can combine it with compressions to work on a 2 rescuer sequence. We'll pause here to get into position. Now that we're ready, let's practice using the bag mask device. Follow along with the video. Here we go in 3, 2, 1. Give 2 breaths. Watch for chest rise. Give 2 breaths. Give 2 breaths. Give 2 breaths. And give 2 breaths. Let's move into special considerations. In this lesson, we focus on mouth-to-mouth breaths, rescue breathing, breaths with an advanced airway, opioid-associated life-threatening emergencies, and maternal cardiac arrest. This section shows how to give mouth-to-mouth breaths when a barrier device isn't available.
Mouth-to-mouth breathing is a quick and effective way to provide oxygen to a victim. Each breath you take contains about 21% oxygen. When you provide a rescue breath, that breath contains about 17% oxygen. This is why rescue breaths are effective in providing oxygen.
Let's go through the steps to deliver mouth-to-mouth breaths. Start by holding the person's airway open with a head tilt chin lift. With your hand on the forehead, use your thumb and index finger to pinch the nose closed.
Now, take a regular breath and seal your lips around the person's mouth, creating an airtight seal. Give 1 breath, blowing for about 1 second. Watch for the chest to rise as you give the breath. If the chest doesn't rise, repeat the head tilt chin lift. Give a second breath, blowing for 1 second while watching for the chest to rise. If you can't ventilate the person after 2 attempts, check for an airway obstruction, but then promptly return to chest compressions. Make sure you give each breath over 1 second and deliver air just until you make the person's chest rise.
Today, we've looked mostly at the procedures you should perform when someone does not have a pulse. But you should also know what to do if someone has a pulse but is not breathing effectively. When that happens, rescuers should give breaths without chest compressions. This is known as rescue breathing. For adults, give 1 rescue breath every 6 seconds. Also, give each breath over 1 second and make sure that each breath results in visible chest rise. During rescue breathing, you should also check the person's pulse about every 2 minutes. Get ready. Begin in 3, 2, 1. Give 1 breath. Give 1 breath. Give one 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 breath.
Another way to deliver breaths is with an advanced airway. Devices such as laryngeal mask airways, supraglottic airway devices, and endotracheal tubes are types of advanced airways that are more secure for providing breaths. These devices help prevent gastric inflation and airway obstruction. Placing these devices requires special training that we won't cover in this course, but you should know how to give breaths when an advanced airway is in place. When you provide CPR to someone with an advanced airway, the ratio of compressions to breaths changes. Instead of providing 30 compressions in 2 breaths, you'll perform continual compressions at a rate of 100 to 120 per minute, while another rescuer gives rescue breaths. In other words, when an advanced airway is in place, you won't pause compressions to give breaths. This goes for victims of all ages, and not pausing compressions allows blood flow to the heart and brain to remain high.
An opioid-associated life-threatening emergency is one condition that might weaken or stop a person's breathing while they still have a pulse. Opioids are medications used primarily for pain relief. In high doses, these medications can cause a person to stop breathing or can even cause death. Naloxone is a medication that can reverse the effects of opioids and may restore normal breathing. Common ways to give naloxone are intravenous, intramuscular, and intranasal. If you suspect an opioid-associated life-threatening emergency in an adult who is unresponsive and isn't breathing normally but has a pulse, you should give one rescue breath every 6 seconds. Then, if your local protocol allows, give naloxone, but do not delay breaths to give naloxone. If the person does not have a pulse, you may give naloxone after starting CPR, but do not delay compressions. For further information on opioid-associated life-threatening emergencies, please consult your provider manual.
Treating cardiac arrest in someone who's pregnant can come with heightened anxiety because 2 lives are at stake. In addition, some rescuers may be unfamiliar with handling the visible anatomy of a pregnant woman. The best outcome for both the mother and the baby depends on BLS rescuers summoning help, providing high-quality CPR, and using an AED without delay. Compressions, ventilation, and AED use are mostly unchanged. If the abdomen is visibly rounded and additional help is available, rescuers should manually displace the rounded abdomen to the mother's left side during compressions to help with blood flow to the heart. More information is available in your provider manual. C will include the portrayal of advanced life support skills. As a BLS provider, you may be on a team with advanced life support providers, but rest assured, those skills are not part of this training. However, no matter the skill, procedure, or equipment used in a resuscitation event, BLS must continue.
Successful teams not only have medical expertise and mastery of resuscitation skills, but they also practice good communication skills and adhere to the key elements of effective team dynamics. Team dynamics is an element of high-performance teams and can be broken down into 3 categories: roles and responsibilities, what to communicate, and how to communicate.
Clear roles and responsibilities should be immediately established by the team leader or the first rescuer on the scene. When all team members know their roles and responsibilities during a resuscitation attempt, the team functions smoothly.
The ideal situation is when multiple rescuers work as a team to perform all the needed roles in a resuscitation attempt. This figure identifies 6 possible team roles for a resuscitation. Note that some roles are typically performed by advanced providers. If enough rescuers are present, each rescuer takes a role. If the team has fewer than 6 rescuers, some team members may be assigned more than one role. Some roles have a higher priority than others.
The compressor assesses the victim and stays next to the victim's chest to perform chest compressions. When giving compressions, rescuers should switch compressors after every 5 cycles of CPR, about every 2 minutes, or sooner if tired.
The rescuer positioned by the victim's head maintains an open airway and delivers breaths while watching for chest rise and avoiding excessive ventilation.
The team member operating the AED, or the monitor defibrillator, can also serve as the CPR coach. The role of the CPR coach is to focus on team members' performance of high-quality CPR and to provide feedback as needed during the resuscitation attempt.
Every resuscitation team must have a defined leader who assigns roles and makes treatment decisions. Often, the team leader will be at the foot of the victim. However, the team leader may move around to observe and evaluate the skills of the team and to provide feedback when needed.
The timer recorder keeps a record of the events that occur, including frequency and duration of interruptions and chest compressions, time of shock delivery, and medication administration. When only 2 rescuers are present, they typically take the roles of compressor and airway, with one of them also covering monitor defibrillator and team leader. If 3 rescuers are present, they take positions around the victim in the 3 critical roles: compressor, airway, and monitor defibrillator.
Every member of the team should know his or her limitations. Team members should ask for assistance and advice early, not when the situation deteriorates.
I'm getting pretty tired during these compressions. I'm gonna need some help after this.
Sometimes a team member or the team leader may need to correct actions that are incorrect or inappropriate. It's important to be tactful, especially if you need to correct a colleague before they make a mistake.
And now you're too fast. Target heart rate is 110.
The next category is what to communicate. Knowledge sharing and summarizing information are critical components of effective team performance. Team leaders should review what's happened and ask for ideas and observations from team members.
Can you give me a recap, Nick?
Yes, we've been doing CPR for about 4.5 minutes. We've got 1 shock, 2 no shocks, and you've given 1 dose of Epi IV.
Okay. So anybody have any ideas on what else we can try with this patient?
The last category is how to communicate. Closed-loop communication is the process of verifying that the message sent was received as intended. It also verifies that any assigned tasks have been completed.
So Scott, why don't you give 1 milligram of epinephrine?
1 milligram of epinephrine IV.
In addition to using closed-loop communication, teams should use clear messaging to help prevent misunderstandings. Teams that work together frequently can create terms or phrases that have specific meaning for them to ensure clarity among members.
145.
Okay, let's go ahead and charge up.
Charging.
Do we have good pulses with CPR?
Good femoral pulses with CPR still.
Finally, teams need to communicate with respect. Speak to each other in a professional manner, regardless of scope of practice or expertise. Resuscitation events are stressful and emotions can run high. Understand that this is the nature of CPR and remain focused on the life you're trying to save.
A high-performing team achieves specific performance metrics, including a high chest compression fraction, or CCF. CCF is the amount of time spent doing high-quality chest compressions during a cardiac arrest resuscitation attempt. You can only achieve a high CCF by eliminating pauses during high-quality CPR.
The Resuscitation Outcomes Consortium trials, or ROC trials, showed that a 10% increase in CCF is roughly equal to an 11% increase in survival. Pauses typically occur during intubation, rhythm analysis, pulse checks, compressor switches, and defibrillation. We'll address some best practices for eliminating pauses in some of these areas, but you'll also need to measure high-quality CPR metrics at your own place of practice to identify other areas where pauses exist. You cannot improve what you do not measure.
Whenever compressions are paused, compressors should hover their hands over the chest and be prepared to resume compressions.
As a BLS provider, you may notice that advanced providers check for a pulse, pre-charge the defibrillator, and prepare to deliver a shock about 15 seconds before pausing compressions at the end of each 2-minute cycle. When using an AED, the prompts will instruct you when to pause. For example, during rhythm analysis or shock delivery.
Switch compressors with the second compressor coming in from behind the first. This allows the second compressor to have the same view of the team, and in particular of the AED or defibrillator. For seamless transitions, switching between cycles every 2 minutes is best. However, if a compressor needs to switch because of fatigue, coordinate the switch to happen as fluidly as possible, such as while delivering breaths.
3, 2, 1, switch.
It's a best practice to use real-time feedback devices during CPR. However, if a feedback device isn't available, a metronome can help establish the proper rate. If your AED or defibrillator doesn't have a metronome, you can download a metronome app to your mobile device before the conclusion of this course.
It's not enough to know what to do or even how to do it. To obtain the best results, your team must perform both the what and the how flawlessly. That requires practice, and effective practice requires measurement. But measurement is only effective if you debrief the team, set goals to improve, and practice more. Again, you cannot improve what you do not measure. For more information on how your team can implement this type of program, talk to your instructor. Ideal situation for performing BLS is having a team with multiple rescuers who can perform all needed roles.
Your team will be asked to treat a cardiac arrest victim. Your instructor will read a scenario and assign a role to each of you. These roles include team leader, compressor, airway, medications, monitor defibrillator, and timer recorder. Some team members may be assigned multiple roles. This scenario will run for 10 minutes with the goal of providing high-quality CPR and enforcing the principles of highly effective teams. This exercise is purely practice and not a test. The exercise will, however, reinforce skills performance and improve the overall resuscitation provided to the patient.
To evaluate the resuscitation, your instructor will be looking for high-quality CPR, which includes compressing at least 2 inches or 5 centimeters on an adult victim at a rate of 100 to 120 per minute, allowing complete chest recoil between compressions and avoiding excessive ventilation. Another critical component of high-quality CPR is minimizing pauses in compressions, so your instructor will be measuring chest compression fraction, or CCF.
CCF is the proportion of time during a resuscitation attempt when the patient is receiving chest compressions. Fewer interruptions are associated with increased ROSC and increased likelihood of survival to hospital discharge. Targeting a high CCF is desirable for survival outcomes. A chest compression fraction of at least 60% is recommended, and a goal of 80% is often achievable with good teamwork. At the end of the exercise, your instructor will conduct a debriefing session to determine where improvements could be made in future attempts. Now that we've covered adult BLS, let's discuss BLS for children. It may be difficult to imagine a child being a victim of cardiac arrest, but it certainly happens. Pediatric cardiac arrest isn't as common as adult cardiac arrest. In adults, the cause of cardiac arrest is often cardiac related. But in children and infants, cardiac arrest is often due to respiratory problems, such as airway obstruction, drowning, opioid overdose, or seizures.
There are some differences in BLS for children, including the chains of survival. Like the adult chains of survival, the pediatric chains have 6 links. Both pediatric chains include prevention of cardiac arrest, activation of the emergency response system, high-quality CPR, advanced resuscitation, post-cardiac arrest care, and recovery. In a hospital setting, the difference is the first link. It focuses on early recognition and prevention of cardiac arrest, which emphasizes patient monitoring and assessment.
Before we get to the practice, let's talk about a few important differences between BLS for children and BLS for adults. First, under the AHA BLS guidelines, anyone from age 1 year old to puberty is considered a child. Under these guidelines, puberty is defined as chest or underarm hair on boys and any breast development on girls. When you're performing compressions on a child, it's fine to use 1 or 2 hands, whichever works for you and allows you to provide deep, effective compressions.
To be effective, your compressions must go to a depth of at least 1/3 the depth of the child's chest. That's approximately 2 inches or 5 centimeters. And the chest must recoil completely between compressions. Also, whether the victim is a child or an adult, a single rescuer always uses a compression to ventilation ratio of 30 compressions to 2 breaths. However, if you're a 2 rescuer team and the victim is a child, the ratio changes and should be 15 compressions to 2 breaths.
It's important to note that giving breaths to children requires less volume and force than giving breaths to adults. Breaths that are too large or forceful have greater potential to cause lung trauma in children than in adults. However, you still need to provide enough air to see the chest rise.
Another difference is when to activate the emergency response system. If you do not witness the arrest and you're alone, you should perform 5 cycles of CPR to deliver oxygenated blood to the victim's brain before you activate the emergency response system. If the child has an adequate pulse but is not breathing normally, it may be due to a respiratory problem, so you must provide rescue breaths. Deliver 1 breath every 2 to 3 seconds or 20 to 30 breaths per minute.
If you are alone and witness a sudden arrest, leave the child so that you can activate the emergency response system and get the AED. Then return to the child to perform CPR and use the AED.
Now, let's combine the BLS skills that you've learned for adults with the differences we just reviewed to practice BLS for children. For this session, we'll practice 2 rescuer child CPR by using a 15 to 2 compression to ventilation ratio. One person will provide compressions while the other delivers breaths with a bag mask device. We'll pause here while everyone gets into position.
So let's count down to compressions and get started with 2 rescuer CPR for children, starting with scene assessment. To stay together, follow the prompts on the screen. Let's go in 3, 2, 1.
Hey, are you okay? Are you okay? Activate the emergency response and get an AED. There's no breathing, no pulse. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
Rescuing an infant can feel completely different from rescuing an adult, but the principles of CPR for infants who are younger than 1 year old are essentially the same as for adults. There are just a few differences, but those differences are significant.
So let's take things in the same order we used for adult BLS. Right now, we'll talk about the skills for 1 and 2 rescuer infant CPR.
First, if the cardiac arrest is witnessed, check the infant for a response and breathing. If the infant is unresponsive and isn't breathing or is only gasping, send someone to activate the emergency response system and get an AED. If you're alone and don't have a mobile phone, take the infant with you to phone emergency services. Or, if necessary, leave the infant and find a phone. But if no one witnessed the infant's collapse and there's no response or breathing, check for a brachial pulse immediately. If you do not detect a pulse, perform 2 minutes of compressions and breathing before activating emergency response if it hasn't already been activated.
If an infant has an adequate pulse but isn't breathing normally, rescue breaths may be required. Deliver 1 breath every 2 to 3 seconds, which is about 20 to 30 breaths per minute. To check an infant's brachial pulse, first place 2 or 3 fingers on the inside of the upper arm between the elbow and shoulder. Then, press your index and middle fingers gently against the inside of the upper arm for at least 5 seconds and no more than 10 seconds. If there is no pulse, or if the heart rate is less than 60 per minute with signs of poor perfusion despite adequate oxygenation, begin CPR.
To begin CPR, there are 2 options for hand and finger placement when performing compressions on an infant. The first technique is to place the tips of your 2 fingers on the sternum or breastbone in the center of the infant's chest just below the nipple line, but be careful not to press on the bottom of the breastbone.
The other is the 2-thumb encircling hands technique. Place both thumbs side by side in the center of the infant's chest on the lower half of the breastbone. In very small infants, your thumbs may overlap. Don't apply any pressure on the tip of the breastbone. Now, encircle the infant's chest and support the back with the fingers of both of your hands. In this position, both thumbs will be used to depress the breastbone.
Whether using the 2-finger or 2-thumb encircling hands technique, once in the correct position, push hard and fast to a depth of at least 1/3 the depth of the chest, or approximately 1.5 inches or 4 centimeters. And the rate needs to be at least 100 to 120 compressions per minute. After each compression, allow the chest to recoil completely.
As we get ready to practice infant chest compressions, remember these key points. Deliver compressions at the rate of 100 to 120 per minute. Make sure the depth of the compressions is at least 1/3 the depth of the chest, or approximately 1.5 inches or 4 centimeters. Allow the chest to completely recoil after each compression, and count out loud as you deliver 30 compressions. So, let's get into position to practice compressions. Let's go in 3, 2, 1.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Now it's time to practice 2-rescuer infant CPR. But before we begin, let's note a couple of differences between 1-rescuer and 2-rescuer infant CPR. One difference is the hand and finger placement for giving compressions. In 2-rescuer infant CPR, the person doing compressions should always use the 2-thumb encircling hands technique. Here are the steps. Place both thumbs side by side in the center of the infant's chest, on the lower half of the breastbone. In very small infants, your thumbs may overlap. Do not apply any pressure on the tip of the breastbone. Now, encircle the infant's chest and support the infant's back with the fingers of both of your hands. In this position, use both thumbs to depress the breastbone at least 1/3 the depth of the infant's chest, or approximately 1.5 inches or 4 centimeters.
The other key difference between 1-rescuer and 2-rescuer infant CPR is the compression to ventilation ratio. As mentioned before, instead of a 30-to-2 ratio in a 1-rescuer situation, 2 rescuers should use the ratio of 15 compressions to 2 breaths. So let's practice compressions for 2-rescuer CPR. As a reminder, make sure your rate is between 100 to 120 compressions per minute. Use the 15 to 2 compression to ventilation ratio because you have 2 rescuers. Make the compressions approximately 1.5 inches or 4 centimeters deep. Allow the chest to fully recoil after each compression and count out loud for your partner.
Time to practice 2 rescuer infant CPR, starting with scene assessment. We will pause here while you get into position with the mannequins. Here we go in 3, 2, 1.
Hey, are you okay? Are you okay? Activate the emergency response and get an AED. There is no breathing and no pulse. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
There are some differences when you're using an AED for infants and children younger than 8 years old. Some AEDs can deliver either an adult shock dose or a child dose for children younger than 8 years old. A pediatric capable AED will have features that allow a child-appropriate shock, but the available features depend on the type of AED you're using.
Your AED may also include smaller sized pads that are designed for children younger than 8 years of age. If it does, use them. If not, use the adult pads, but make sure that they do not touch or overlap. But never use the child pads for an adult. The shock dose delivered by child pads is too small for an adult and likely won't be successful. It's better to provide high-quality CPR than attempt to shock an adult with child pads. Some AED pads recommend placing 1 pad on the chest and 1 pad on the back for infants and children. Follow the pictures on the pad packages for proper placement.
If an infant needs defibrillation, a manual defibrillator is preferred. But as we mentioned before, this device is quite different from an AED, and it requires special training that is not included in this course. If a manual defibrillator is not available, an AED with a pediatric dose attenuator is preferred. But if neither is available, you may use an AED without a pediatric dose attenuator.
When food or other items block a person's airway, choking occurs. In a severe airway obstruction, the person usually has signs of poor air exchange and breathing difficulty, such as a silent cough, an inability to speak or breathe, or cyanosis, that is, turning blue. Adults or older children who are choking may clutch their neck with both hands, making the universal choking sign. If someone indicates that they are choking and cannot talk, you must act. For someone who is standing, you'll perform an abdominal thrust.
To perform an abdominal thrust, stand or kneel behind the person and place your arms around the waist. With one hand, locate the navel. Then make a fist with your other hand and place the thumb side of your fist against the person's abdomen, just above the navel and below the breastbone. Grasp your fist with the other hand and press your fist into the abdomen with a quick, forceful upward thrust. Repeat thrust until the object is expelled from the airway or the person becomes unresponsive.
If you can't wrap your arms around the waist because the person is pregnant or overweight, or simply can't stand, wrap your arms around their chest and give chest thrusts instead of abdominal thrusts.
If you're not able to relieve choking in an adult or child, or if the person becomes unresponsive, have someone activate the emergency response system. Then lower the person to the ground and begin CPR.
Perform CPR as usual, but with one difference. Each time you open the airway to give breaths, look for the obstructing object in the back of the throat. If you see an object that can be easily removed, carefully remove it. But do not perform a blind finger sweep because this may cause the object to become lodged farther back in the airway.
Choking is also a fairly common emergency in infants. The steps to relieve choking in an infant are quite different from those for older children and adults. If you find an infant who is choking but is still responsive, first sit or kneel with the infant in your lap. Hold the infant face down and resting on your forearm with the head slightly lower than the chest. Support the head and jaw with your hand. Avoid compressing the soft tissue of the infant's throat.
Then, rest your forearm on your thigh to provide support. With the heel of your other hand, deliver up to 5 forceful back slaps between the infant's shoulder blades. Deliver each slap with sufficient force to attempt to dislodge the foreign body. Then, place your free hand on the infant's back, supporting the head with the palm of your hand. This will cradle the infant between your 2 forearms as you turn the infant over while carefully supporting the head and neck.
Keep the infant's head lower than the chest and deliver up to 5 quick downward chest thrusts in the same location where you would perform compressions, just below the nipple line, over the lower half of the breastbone. Do this at the rate of about 1 per second. Repeat the sequence of 5 back slaps and 5 chest thrusts until the object is removed or until the infant becomes unresponsive.
Now that you're in position, let's begin. Follow along with the video as you practice. Here we go in 3, 2, 1.
1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5.
As with an adult, if a choking infant becomes unresponsive, shout for help and have someone activate the emergency response system. Then, lay the infant face up on a hard, flat surface. You'll perform CPR as usual, but with one difference. Each time you open the airway to give breaths, look for the object.
To give breaths for an infant, the mouth-to-mouth and nose technique is preferred. For this technique, you will first open the infant's airway with a head tilt chin lift. Then, place your mouth over the infant's mouth and nose to create an airtight seal. Give 1 breath, blowing for about 1 second. Watch for the chest to rise as you give the breath. If the chest does not rise, repeat the head tilt chin lift to reopen the airway and try to give a breath that makes the chest rise. If you cannot cover the infant's mouth and nose with your mouth, use the mouth-to-mouth technique instead. The mouth-to-mouth technique for an infant is the same as for an adult.
If you can see the object, carefully try to remove it. Never perform a blind finger sweep. You should only try to remove an object if you can see it. If you're alone, after about 2 minutes or 5 cycles of CPR, activate the emergency response system. We'll pause here while you get into position to practice with the infant mannequins. We covered a lot today. You learned the proper BLS rescue techniques of CPR and the use of an AED for all age groups, the importance of effective teamwork, as well as how to perform in a 1 rescuer or 2 rescuer scenario. You've also learned rescue breathing and what to do for someone who is choking.
Thank you very much for your time and attention today, and especially for your commitment to learning these critical life-saving techniques. We appreciate and honor the important work you all do as healthcare professionals.